Hello, everyone. Welcome. We are going to go ahead and get started since we have a lot to cover in just 1 hour. I will just quickly introduce you all to what we're going to cover here today. Welcome to this virtual event. Today we're talking about addressing VTE Risk Assessment, the role of public affairs. I'm Lily Reiser, part of the Secretariat of the European Thrombosis and Hemostasis Alliance, or ETHA for short. And this presentation is hosted by the ETHA and its parent organization, the International Society on Thrombosis and Hemostasis, or ISTH. As a bit of an introduction, in case either the ETHA or ISTH are new to you, I want to tell you a bit more about these two organizations. Both the ETHA and ISTH are organizations comprised of researchers and clinicians working in the field of blood clotting disorders at the European and international levels, respectively. Both organizations aim to raise awareness of thrombosis and hemostasis with a wide range of stakeholders, with patients, clinicians, policymakers, the general public, to prevent unnecessary disability and death from these conditions. I'm sure that everyone on the line already knows about the devastating impact of blood clots. Many of you will have an academic background in hematology and will know these disorders like the back of your hand. However, the aim of today's event is to provide you with the tools to communicate about these issues with non-experts, so perhaps with people who don't even know what thrombosis is. But we hope that the messages from today's presentation will help you to coordinate and execute your own awareness-raising activities, whether that be with the Ministries of Health, regional hospital associations, or patient groups. We'll be discussing VTE Risk Assessment in close detail as a great success story of public affairs efforts, but these strategies can be applied to any advocacy work that you do on thrombosis and hemostasis. So today we'll hear from two experts in the field of public affairs. I would like to first give the floor to Nick. Well, we'll hear from James Tyrrell a bit later, but we'll start by giving the floor to Nicholas White, who is a Senior Director in APCO Worldwide's Brussels office, who will give us an overview of what public affairs is. So James, thank you. We'll welcome you again later. An introduction to Nicholas. Nicholas has more than 2 decades of experience in international affairs, advocacy, and research. He counsels APCO's clients on ally development and coalition building, advocacy, public affairs, and strategic communications. Nicholas leads the global solution practice in APCO's Brussels office, overseeing work with a strong geopolitical dimension, including APCO's work with the 2018 Bulgarian presidency of the European Union. And he was recognized in 2017 and 2018 as one of the top 40 online EU influencers on Twitter. So thank you, Nicholas. I'll hand it over to you.
Well, thank you very much, Lily, and thank you everybody for attending this session. And for me, it's interesting because explaining what public affairs is it's almost like asking a fish to explain the water that it swims in. I've been in Brussels for 21 years. I've been in the public affairs advocacy side of things, I guess, for 14. Among the things I've done, I advised the most recent 3 countries that became independent: Montenegro, South Sudan, and Kosovo. I've also worked on a number of health-related issues, and I'll talk about one of them a bit later on. I found this a really useful exercise just to think about what I do. I hope what you get out of this today is a better understanding of what public affairs is, an understanding of what good practice looks like, and give you the ability to undertake public affairs activities yourselves, advocacy, whether it be on thrombosis or whether it be on something else. What is public affairs? I mean, we've used this rather jargony title for the webinar. I mean by public affairs, getting the public policy outcome you want, and this will be by direct communication with the policymakers who decide things, but also shaping the environment, ensuring that the discussion around particular issues is going your way. Government officials are strange. They live in their own universe. The way they behave is sometimes obscure and difficult to grasp, as Monty Python pointed out so many years ago. How do we make them listen to us? How do we get them to take on board our concerns? Within the public affairs universe, I see three modes of action, as it were. The first one, the one that takes up most of our time, is government relations. It's building a relationship with both the elected officials and the appointed officials who are relevant to our topic. I've got nice pictures here of Angela Merkel and President von der Leyen of the Commission, and I fear concealed a bit, you may see her von der Leyen's predecessor Juncker talking to his successor as Prime Minister of Luxembourg. But we must always remember that these are human beings who we're dealing with on the other side of the table. As well as government relations, to do public affairs properly, we need to have a function of issues management, a systematic process of monitoring what's going on, staying in touch with the people who we care about, which will include not just government officials, but also people outside the government circuit, like most of you, I suspect, like other pressure groups, like industry coalitions. I'm sorry, another jargony word, but by an industry coalition, I simply mean a formal group of people who are interested in the same particular policy area. And then the crucial point in the public affairs universe is lobbying. And this is when we have a specific legislative or regulatory outcome in mind. It's the specific thing that we want to change. And that requires a slightly different mode of engagement with the universe. How do we build a campaign strategy that will work? And we have to start off with understanding of the issue. I mean, you are all experts, so I think you don't have a problem with the understanding of the particular issue that you're concerned with. But then from the policy point of view, we need to understand what is driving the issue, who cares about this, why does it matter to them. Another really important point is localization, making something personal or at least local. Most people who are in public office come from a particular place. They're responsible to a particular community. That's the people who they will listen to. That's the people who they will care about. Identifying the key stakeholders, and I'll come back to this term in a moment, but essentially making sure that we know who the people are that we need to be talking to. Who are the people that we need to perhaps not talk to? I've had a case of a client where I was strongly advised that they should not engage with the media in a particular country because their reputation was already so bad that calling attention to them would actually be counterproductive. So this all comes down to identifying the key lobbying targets that we have and the key third-party supporters. Again, we have this awful term stakeholders to describe all of these people. Who are stakeholders? I like to break them down into 5 categories, each one of which requires their own distinctive approach. The most important type of stakeholder is the decision maker, the minister, the commissioner in the Brussels universe. It might be a secretary general of an organization. It might even be a prime minister or a president, the person whose signature you need on the dotted line to make the thing that you want happen become law or become effective. So that everything that you do needs to be aimed at changing that person's mind or preventing them from changing their mind sometimes. But the group of people you spend the most time in dealing with is their advisors. That can be their private office, it can be the line bureaucrats in the ministries, it can be the political appointees that they listen to, or indeed people in their political parties who are responsible for advising them on particular issues as well. They will take up most of your time, but there are 3 other groups that we have to pay attention to as well. The next most important is the media and also social media. Lily was kind enough to mention that I do a little bit of tweeting on the side. I'm afraid if you look at my Twitter today, you'll find that it's all American elections. But the media are a shortcut into the minds of the decision makers. They're paid to listen to their advisors, and their advisors are paid to advise them. But we all know that simply reading an article in the newspaper, seeing a television program, reading a tweet can actually be quite an effective mobilizer of opinion on behalf of the people whose opinions we need to change. The fourth group is, I think, the group that most of you in this webinar are in, the wider policy world, non-profits, think tanks, academia, industry associations, researchers, all of the people who are contributing to the policy landscape that we inhabit, all of them members of what has been called the epistemic community, the people who care enough about a particular issue to take a stance on it. The people in the wider policy world take ages often to come to a particular policy determination, but for precisely that reason, they're often listened to a great deal more. And then the fifth type of stakeholder, who again requires pretty much their own subdiscipline, is dealing with parliamentarians. It tends to be members of parliament that the decision makers really respect or fear. Actually, not usually both, it's usually one or the other. But we also have to bear in mind that members of parliament are themselves future ministers, future deciders, possibly even past ministers, past deciders. So that's the, as I say, when I'm planning my own campaigns, I look at each of these 5 groups and think about what my approach is going to be to each of them. And sometimes, you know, there can be times that you deprecate one of these, that you concentrate on the others. But in general, these are the 5 types of stakeholder that I look at. To define a campaign strategy, this is all fairly straightforward, but it does need saying. It's important to define your campaign's objectives. It's important to define the key messages and arguments that you will use. And these will very often not be the ones that you care about internally. These will often need to be aimed at the interests of decision makers who are perhaps facing elections or involved with a much bigger issue of which your issue can become part. Those people themselves need to be classified, defined, prioritized. You need to decide what it is who it is you're going to reach out to. And then you need to work out who is going to carry your message. Who will be your internal spokespeople? Will it be the head of your organization? Will you have somebody whose specific job it is? Will you perhaps have an external group representing your interests who will also be in general the message bearers? It's a strategy that sometimes works. And most important of all, it's important to define a timescale by which you're going to get these things done. Quite often this will be imposed by external events. There'll be a particular meeting or an election or a legislative process that's underway. It's not always the case. And I must say, even if it's not the case, it's just quite helpful for one's personal sanity to have a timescale and say, this is the time by which we will hope to have achieved these goals. So that's the sort of framework, the tools that we use, and I'll go into these in a bit more detail in a moment, but and some of this, of course, is unfortunately more difficult right now. But meeting programs one-on-one with the policymakers, which could include phone calls. Having an event can be extremely effective as well. These days, we're increasingly having to move online. Using the media, I mean, journalists use you, but you must use them. And it's our job in public affairs to give them what they want, which is a good story. And also, crucially, coalition building, finding people with similar interests with whom you can act together. And one shouldn't forget the importance of having good supporting materials, hard copy very often these days, even these days, I should say, even these days of virtual living. Briefing papers, which can be effectively just simply stating your case in a couple of pages. Position statements can be even shorter. There's a sort of declaration by a body, by a group of people, that they share your position, hopefully. Studies or research, and this is the much longer sort of academic product, which is still extremely important in the policy world, although you may find yourself having to explain what your research actually says to people who haven't had time to read it in full. And then a really effective technique from our world is the leave behind, and that's simply a single sheet of paper summarizing the key arguments, which you hand over at a physical meeting and literally leave behind for your interlocutor to look at and for them to keep on their desks. If you're interested, and I'm sorry, I think the photographs are, my image is partly obscuring this, but there's a really good book by a researcher called Christine Mahoney, I think at Rutgers in the States, and she looks at Brussels versus the Beltway, comparing the way in which we do advocacy in Brussels and how that stacks up when you look at what happens in Washington. A lot of very interesting conclusions. I think, not surprisingly, more similarities than differences. And the biggest similarity is that expert meetings actually are the single most effective thing. So we're in the right zone. The best way of engaging with people, and this I hope is fairly straightforward, but it needs again to be just laid out, because this planning engagement is what takes time as well as doing it. It's organizing your direct meetings with the key stakeholders, with the number ones if possible, definitely with the number twos, the advisors, and with anybody else who is possible, who you can reach out to. Taking part with the initiatives that your allies are doing as well, adding strength in that way. Building a coalition for joint action with your allies, with like-minded groups and individuals, and actually having an event on a dedicated topic can be tremendously effective to confront the officials who are dealing with your dossier, with you and with your activists and with your experts, and having a public discourse where they are having to be accountable for what they are doing or not doing. That can be tremendously effective and a great focus sometimes even for decision making on its own. To be a public affairs practitioner, you have to mobilize a few arguments that are based on fact. Factual arguments are always much more powerful, but they can be expressed in an emotional way. Building a broad base of support, starting with the officials and working upwards, identifying those key audiences, being sensitive to the timing of the external calendar, making sure that you're not clashing with a point when people are all worrying about a different topic entirely. Building relationships with the officials that you're dealing with and the others who you're dealing with, not merely names in the address book. And the aim of this is always to generate dialogue and not noise. And it's to establish yourself as a useful resource, as a helpful resource, as somebody who will help your targets to do their job better, and not to be a source of, not necessarily to be a source of irritation. I mean, irritation has its role as well. As they say, it is the squeaky wheel that gets the grease. Of course, each of these different audiences that you're dealing with will require a slightly different approach because they're coming from a slightly different direction, working to a slightly different agenda for slightly different sets of people. I've got a couple of general points and a case study. General point on ethics, and this is quite important in our universe. Our profession doesn't always have the greatest reputation, and I think it's important to unpack this. The public does have a right to know who is spending money on influencing politics. And it's more about the people we deal with than with us. They need to be accountable as public servants for their interactions with us. Most countries now have transparency legislation. When you're engaged in public advocacy, you will have to comply with it. We public affairs companies also have a code of conduct. We, APCO, will not accept clients who are not willing to commit to the same ethical standards that we are. It still leads to misunderstandings. The Financial Times last week ran a story with the shocking news that Google actually has a public affairs strategy. I should, just to make it clear that APCO doesn't actually work for Google. In fact, I think in this particular case, we're working against them. I probably shouldn't say that. But I mean, for me, this was not a news story, the fact that Google is planning how it will engage with the European Union. But Financial Times chose otherwise, and I guess they've got newspapers to sell. The key questions to ask yourself: what do we say? Who do we say it to? How do we say it? When do we say it? And timeline. Time, of course, is the one resource that you never get any more of. I was asked to give a couple of thoughts about how the current situation has changed public affairs, and it has had an impact. I think we can't deny it. I think all of us are affected by the situation one way or another. It's certainly led to a change of work habits. You'll see that I'm speaking to you from my home. I think everybody else is as well. For some people, their personal situation may have changed for the worse as a result of the pandemic. And in this situation, self-care is critical, making sure that we maintain our own work-life balance. On the work side, I found it much more difficult to develop new contacts, but on the other hand, I found it possibly enriching some of the existing relationships that I had. People are feeling isolated and appreciate it when you reach out to them. But it also means that people's concentration is a bit limited for anything outside the issue of the day, whatever it may be. So I think we just have to all be sensitive to that. And very specific issues, therefore, take a bit longer to mature, which may or may not be a bad thing. I'm going to finish with a case study in the health sector. I've been working for the last few years advising Rotary on the campaign, the global campaign to eradicate polio. It's an issue that directly affects many people, and certainly anybody of my age will have older relatives who are polio survivors themselves. And it's still a live issue in Afghanistan and in Pakistan, and until recently in Nigeria. 5 years ago, when he was appointed Commissioner, Mimica, the Croatian commissioner, European Commissioner for Development, gave a verbal commitment to helping the polio campaign, but we found it was being blocked without his knowledge at the bureaucratic level. People within the European Commission felt that our approach was insufficiently horizontal. So the Global Polio Eradication Initiative is a coalition of Rotary with the World Health Organization and UNICEF and the Gates Foundation. Rotary itself has a superb international network with members in every country in the world. We were able to increase pressure on the Commission via members of the European Parliament who were contacted by their Rotarian constituents. Indeed, some of them helpfully turned out to be Rotarians themselves. We held events in the European Parliament, as I've described, to get the Commission in there, force them to explain what they were doing. And eventually we were able to secure 55 million euro from the Commission for the Global Polio Eradication Initiative. And I'm glad to say that it has indeed been eradicated from Nigeria. I'm afraid we're still working on Afghanistan and Pakistan, and I'm afraid this is one of the things that has been hit rather badly under current circumstances. So that's my sense of what public affairs is and means, and I think I would like to hand over to James.
Thanks so much, Nicholas. Really, that's a helpful general introduction to how public affairs works and what it even is. So thank you, really. As we go along, I would like to invite those of you listening in to share any questions that you might have via the Q&A window at the bottom of your screen. So you'll just click on that little button that says Q&A and you can ask questions of our panelists. And Nicholas will welcome you back when we start the Q&A at the end of the this session. So as Nicholas said, next I will be handing the floor over to James Tyrrell, who's the Senior Director in APCO Worldwide's London office and co-leader of APCO's Global Health Practice. James specializes in combining corporate communications and policy consulting to support market access, government relations, and product launches for companies and organizations. with 15 years of experience in public affairs, a lot of that was in the thrombosis and hemostasis space. James has spearheaded a host of award-winning programs and campaigns across a variety of sectors for some of the world's largest companies. And James will be speaking to us today about a specific example of a successful campaign. And I hope that saying it was successful isn't giving anything away. This example should be particularly relevant to this group because it covers a campaign to adopt VTE risk assessment guidelines in the UK. So over to you, James. Thank you.
Thanks very much, Lily. So if we just move on one slide, back in 2005 was when I first started my VTE journey, if you like. I'd never heard of VTE previously. We know that VTE is a blood clot in the leg, a DVT. If it breaks off, it can cause a PE, and together they're known as VTE. But what was really interesting was the numbers, the scale of the problem. 1 in 4 people die from causes related to blood clots. It's, you know, one of the top cardiovascular killers. It's the #1 cause of preventable death in hospital. And 60% of all VTE cases occur during or following hospitalization. This was an issue highlighted to me by a patient advocacy group in the UK, which was then known as Lifeblood. It's now Thrombosis UK. And that's led by Professor Beverly Hunt. And at the time, there was a lot in the media about airline-related DVT, people going on long-haul air travel who were suffering from DVTs. But Professor Hunt came to me and said, do you know what the real scandal is the number of patients who actually die from VTE that they contract in hospital. And she said to us, you know, we really need to do something about this problem. So if we move on one slide, looking at VTE in the NHS, we know that the incidence is about 1 to 2 per 1,000 population. It's estimated there are around 53,000 cases of VTE in the NHS each year. You know that we can reduce that mortality rate if we treat it and prevent it. And it was estimated that 60% of cases of VTE were associated with hospitalization, and that as many as 2 in 3 could be preventable. So there was consensus amongst clinicians that routine risk assessment of patients and the administration of prophylaxis, whether that be pharmacological or mechanical, would really make a difference. So we were briefed to try and effect this change in a huge health system, which was the NHS. So if we just move on, this is quite a good slide that I think shows you first off that effecting change can take time. And this was certainly the case for VTE, and it was certainly a case where VTE, no one had really ever heard of it. So the first thing we did was rename VTE to HAT, Hospital Acquired Thrombosis. This was something that people could understand. Thrombosis, they could relate to deep vein thrombosis that everybody was aware of because of this media sensation around airline-related DVT. And I think this also shows how, as you move on in time, you need to be able to adapt your approach and stay relevant. So how do we start this campaign? So firstly, we took Professor Hunt to meet with an MP who had an interest in VTE. There was a clinician who was an MP, Dr. Richard Taylor, and he sat on the House of Commons Health Select Committee. And that committee's job is to look at big health-related issues of the day and bring them to the attention of government. So he was astounded at the numbers, the figures of people potentially dying in the NHS. And he was able to secure a Health Select Committee inquiry on hospital-related VTE. Now, that was really important because when the Health Select Committee publishes a report, the government is duty-bound to respond to that report and respond to the recommendations which it came up with. So the Health Select Committee recommended that there should be a national approach to VTE prevention. There should be the development of a national risk assessment tool, and that in time we need to develop an expert working group to monitor this situation. So that was the first step. Secondly, in 2006, we decided to assemble a group of interested MPs. So this was MPs who had constituents who had unfortunately died from VTE, NPs who had a personal experience of VTE themselves. The chair of our group actually suffered a pulmonary embolism. And we were able to essentially create this group to police the recommendations of the Health Select Committee inquiry. So once the Chief Medical Officer established this group in recognition of the costs of VTE, both the human cost, 25,000 avoidable deaths, but also the financial cost of VTE, which is estimated to be around £650 million per year, we were able to put this on the radar of the NHS. So there was recognition of VTE as an area of concern. And in 2010, the Department of Health established the role of the National Clinical Director for VTE prevention. It was ambitious in design, mandating VTE risk assessment of all adult patients on admission to hospital, utilising a national VTE risk assessment tool. So this was really key, was developing this risk assessment tool that hospitals could use. In time, hospitals were then required to report the number of patients that had undertaken a VTE risk assessment. And a national target of 90% of all patients to be risk assessed was put in place. At the same time, national guidance and a quality standard defining best practice in VTE prevention were published concurrently. And as we see now in present day, we have reduced our numbers of patients suffering from hospital-acquired VTE, which has obviously improved patient outcomes and reduced costs. So I think what was key here was this Health Select Committee inquiry establishing the problem, developing a group of MPs who could police the recommendations and ensure that change actually took place, getting the clinical community to come together and actually tell the NHS that this is something that was the priority. And it's something that was fighting against other clinical priorities at the time, such as hospital superbugs, MRSA and C. difficile. This was in the forefront of the public imagination due to media focus on those issues. But we had to really reinvent this and use human case studies to bring this issue to life. By putting something in place that measures performance and actually incentivizes the system to affect change, gets things done, and providing education both to clinicians and to the general public was absolutely key. So if we move on one slide, going back to Nicholas's point about setting some objectives, looking at the technicalities of how we affected change in a big system, we decided to use the tools and mechanisms at our disposal. We have an organisation called NICE in the UK that measures cost effectiveness of medicines, but also develops clinical guidelines. And we decided to call on NICE to start creating a system of quality standards for a number of conditions. But we decided to kick this off with VTE prevention. And we outlined what good quality VTE prevention actually looks like. So it starts that risk assessment of VTE. It's important about having shared decision-making with patients by giving them information about VTE as a risk. Patients are provided with anti-embolism stockings at the time, monitored against NICE guidance. Importantly, patients were reassessed for their risk of VTE and bleeding within 24 hours of admission. Those patients at risk were offered prophylaxis. Information was given to them when they were discharged, so they could look out for signs and symptoms. And patients with high risk were offered extended prophylaxis. So that was really key to almost outline the journey. If we look at the next stage in developing a VTE risk assessment, we knew that there were lots of local risk assessments out there in the system, but some hospitals didn't have any at all. So if we move on one slide, you can see how we established VTE risk assessment. So that involved documented evaluation of all surgical patients and medical patients with a significant reduction in mobility for the presence of 19 risk factors for VTE and 10 bleeding risk factors based on a standardized national tool. Pregnancy or within 6 weeks of delivery was listed as a thrombotic risk factor, and specific guidance on VTE prevention in the obstetric population was updated in both 2009 and 2015 by the Royal College of Obstetrics and Gynecology. So the first step was assessing that patient's mobility. The second step was assessing the risk of VTE. So if we move on. And the third step, moving on again, is assessing the patient's bleeding risk, because we wanted to make sure that we weren't putting those patients at undue risk of harm whilst we're trying to do something about the VTE risk. So that's great. We have a VTE risk assessment in the system. How do we get that used and mandated across 150 hospitals in the NHS and 14 million admissions every year? So if we move on, you'll see that we use the NHS standard contract. So the NHS standard contract essentially outlines how hospitals get paid. And at the time, there was a real focus on quality improvement in the NHS. And there was something being considered called CQIN. That was the Commissioning for Quality and Innovation. And this provided a percentage of the tariff that is paid to each trust would only be paid if certain improvement measures were put in place. Now, we made the case that VTE risk assessment could be used as a test bed for that CQIN mechanism. And it was one of 3 national initiatives introduced by the CQIN framework in 2010. And it was unique in that the process applied to every adult patient admitted to an acute hospital. So during the first year of the CQIN incentive payment, the mean VTE risk assessment improved from about 40% to in excess of 91% of all patients. And after 3 years, the goal was increased to 95%. And this has since been exceeded in all subsequent years. So if we move on, one way of looking at the effectiveness of risk assessment on its own is actually whether there was an increase in prophylaxis being offered to patients. NHS Digital previously investigated expenditure on prophylactic low molecular weight heparin, and the volume of units of a variety of medical prophylaxis was evaluated, and it's summarised there. And I think it's important to say the volume of prophylactic low molecular weight heparin was static across 2006 to 2007, but subsequently increased over those years when these mechanisms were put in place. So importantly, moving on, VTE prevention is now embedded as a standard practice in the NHS. So the CQIN levers were put in to prompt that change. Now the NHS is essentially following this as routine care. The incentive payment was taken away and is now being used for other improvement mechanisms. But importantly, we kept these mechanisms within the NHS standard contract. So there is actually a punitive penalty if trusts fall now below the 95% level. So if you move on as well, there are some additional service conditions in the NHS contract that we thought were very important. So it wasn't just about following clinical guidance, and it wasn't just about risk assessing patients. We also put in a contractual measure that root cause analysis of all confirmed cases of pulmonary embolism and DVT acquired by hospital users in hospital were explored, because we needed to understand where there were potentially weak links in the chain. And to use this as a learning mechanism. We always had certain groups of clinicians, and unfortunately the orthopods said they never saw VTE in those cases. Well, that was because those patients usually were readmitted to hospital into the emergency department. This root cause analysis highlighted that a number of patients, as a result of orthopedic surgery, were getting blood clots, and slowly it's changed how orthopods view VTE prophylaxis, which has been really positive. So has this had an effect? So if we move on, there were 3 studies that have looked at the improvements to outcomes. Quality improvement data at a trust level demonstrated increased risk assessment, decreased rates of hospital-acquired thrombosis, and increased rates of appropriate thromboprophylaxis, which was really good. The Quality and Research Outcomes Unit of the NHS found there had been a 15% reduction in mortality nationally when the 90% risk assessment goal had been reached. And Catterick and Hunt found in 2011 and 2012, around 940 deaths owing to VTE were potentially avoided. So what were the key success factors in driving this? If we move on one slide, I think what we could say it was driving through a coalition approach. We were able to get clinicians, politicians, and patient groups all aligned through consensus. we used both national and local evidence, and we all agreed on the policy recommendations that needed to be put in place. And I think the different actors, whether that be Thrombosis UK and Anticoagulation UK from the patient groups, all of the professional royal colleges, the development of a national VTE exemplar network for clinicians, the all-party thrombosis group, the politicians, and working with industry to support this programme, created a win-win. I think moving on, the drivers of success were very much around the evidence. We had the Health Select Committee report stating the problem. We had NICE guidance that was evidence-based clinical guidelines. And the all-party parliamentary group actually did surveys every year to see whether trusts were actually implementing all of these best practices. Targets and measurements, I think, outlines the specific change that is required. We had an incentive with the sequence system that prompted action because trusts recognized they could make money from this. We gave the tools to make it easy for the right thing to be done through the risk assessment tool. We had a system of leaders with the creation of an NHS VTE board. And ultimately, we created local champions and best practice mentors through the VTE Exemplar network. If we move on, the VTE Exemplar sites, this was a network established in 2007 with the aim of using network leadership to reduce avoidable death and disability for VTE. So to become an exemplar centre, those hospitals had to have an existing track record of excellence in VTE prevention and care. They then were able to offer practical support and advice to other hospitals who are seeking to raise the bar in terms of their VTE prevention. This brought together both public and private sector organisations, large teaching hospital trusts, specialist centres, district general hospitals. And this created a website. We had lots of resources that were shared. And this was hubbed out of King's College Thrombosis Centre by Professor Rubenaria, who many of you will know. So that was very much the system. In terms of the public awareness and human interest, if we just move on one slide, it was really important to actually bring this story back to home. It was about highlighting the human interest stories of patients who had either suffered a VTE or relatives of those patients who had unfortunately died. And we actually found Paul Robinson, an England international footballer. He suffered a VTE following ankle surgery. And he was gracious enough to support in a national awareness campaign that really highlighted that anybody can get a VTE. And as he said, I hope that telling my story makes people think, and it even helps a few. So I think combining the political lobbying with some media activity, brings this back to the public imagination, and also it makes politicians follow your case. Moving on, patient empowerment was absolutely vital. So providing information for patients and their families goes hand in hand with professional education and management. And we work closely with the NHS to put all of this information on the main NHS website. We developed a self-assessment tool for patients going into hospital and a number of easily accessible videos to help those members of the public with low levels of health literacy. So moving on, in conclusion, I guess our aim was always to reduce avoidable incidents and death in the NHS. The National VTE Prevention Programme in England has shown the benefit of systematic VTE prevention driven by mandatory risk assessment. This release that you can see here from February of this year shows over a 20% reduction in adverse outcomes. So, we're preventing about 800 deaths a year, which is significant. And I think is one of the most effective patient safety campaigns that's been run in the NHS. We know that more deaths could potentially be saved, but that's largely down to the limitations of thromboprophylaxis and inadequate prophylaxis. But I think this approach requires worldwide adoption. And this is something that the ISTH is now working closely with the WHO to try and spread this internationally. So in closing on my final slide, I think, the NHS story shows we had a comprehensive, systematic approach to VTE prevention, but it took us about 6 or 7 years to implement. It's the first national initiative of its kind anywhere in the world. It's delivering high quality care. It's reducing avoidable harm. It's making hospitals a safer place. We had leadership from the NHS, from parliamentarians, from patient advocacy groups and charities. We have a system in place now to share the best practices through the VTE Exemplar Network. We've delivered change, and those risk assessment rates rose from 50% in 2010 to over 98% now, with a 20.8% reduction. So that shows what is possible with the right ingredients. So happy to take any questions.
Thanks so much, James. And that's a perfect segue into starting the Q&A portion of our session here today. So Nicholas, if I could ask you to come back as well. We will take a few questions from the audience for the next 15 minutes. I'm going to start with a question of my own, and I have seen a few questions come in from the audience as well. So if you haven't had a chance to ask yours yet, please feel free to drop it into the Q&A box. But to start, I wanted to put a bit of a general question back to Nicholas. You mentioned in your overview of who we should be reaching out to as a way of building a campaign for change, that there were maybe 5 different types of stakeholders that we should try to reach. And I noticed that the general public wasn't one of those. So I'm wondering what you think about the role of the general public in a public affairs campaign.
Yeah, it's an awfully good question, and perhaps it reveals the mindset that I have swimming within my little institutional bubble. But I think there are 2 things to bear in mind. The first is that the general public as a whole is a consumer rather than a producer of policies. And in the end, all of the groups who I mentioned are themselves voters, are themselves members of the general public. But when you're in a campaign, in general, your outreach to the public as a whole is frankly for fundraising and for boosting your own resources rather than necessarily for change. The other thing I would say is I mentioned Christine Mahoney's book on Brussels versus the Beltway. One of her other interesting findings is that campaigns on specific issues which rely very, very largely on simply public mobilization, letter writing, petitioning, and so on, these campaigns have one thing in common, which is that they generally fail.
Interesting. Okay, so that is a point of view that I'm not sure matches up to James's experience with the campaign that he just talked us through, because you mentioned that there was an element of public awareness in how you managed to be successful. So maybe if I could get you to disagree with Nicholas a little bit, or expand on what he just said about the role of the public.
And the role of the public is important. I think it's about trying to make your campaign calls relevant for the general public. A lot of people had never heard of VTE. When you mention thrombosis, you know, even now people say, "Oh, that's what you catch on a plane." You know, the media campaign that kind of came out about airline-related DVT actually did us a huge disservice, and we spent a lot of time trying to deconstruct that and saying actually the bigger risk is going into hospital. You're 1,000 times more likely to get a blood clot by going into hospital than you are on an aeroplane. So that was one of the key things there. I think the human interest in making this relevant, and we did a lot of work with patients who had suffered VTE, but importantly, you know, the families of those young people who had, you know, tragically died from avoidable blood clots. You know, that really resonated in getting political backing for our support. So I think it needs to be used effectively. You know, we always use the media, which is a great way of speaking to the public. And ultimately, we were just, our key message was telling patients going into hospital, ask your doctor what you're going to do to safeguard me from getting a blood clot. So I think it is important.
All right. I will allow you the final word on that and move on to a question from the audience to Nicholas. So the question here is, how do you successfully work on the national level to influence both national and EU level policies?
I mean, in an EU member state, it's pretty much one and the same, because European policies are so much built on the concept of taking in as much input from the various actors as possible, that once you're working on a national policy issue, if it has a European dimension, you're already working on a European policy issue. And if you're working on a European policy issue, you cannot ignore the national elements of it. So one maps it out in every single case. And, you know, some cases, like, for instance, when I was lobbying the EU to recognize South Sudan as rapidly as possible after independence, that's a member state competence, but it was also something that was coordinated at the EU level. So I had to make sure that I was targeting both, but targeting them appropriately and respectfully. On the other hand, when there's an EU policy question that's more within the EU competences, then the institutions take up most of your time, but by no means all, because member states still matter. So a good strategy will include both the national and the European elements, or else it doesn't work.
I think certainly from an EU level, one thing that focuses the mind of national governments is seeing where they sit on the leaderboard of spending on clinical outcomes. So actually you can use pan-EU campaigns to drive change at a local level. And we do this in a variety of areas. And it's had an impact in a number of different therapy areas.
So this actually connects to a question, well, perhaps it connects to a question that was posed to you, James. Victor has asked why the UK still has the lowest use of low molecular weight heparin per capita in Europe compared to other countries, despite the most systematic approach of risk assessment for VTE prophylaxis for medical patients. And is that something you can comment on?
It's something I'm not too familiar with the detail on that, Victor, so I'm not going to answer that directly. I would like to see the deaths per capita of hospital-acquired thrombosis. I think that would be a more meaningful metric to look at. And, you know, whether or not our systematic change has made any difference in the great scale of things. So that's what I'd like to see some research on.
But it does raise this point that we were just addressing of it helps to kind of poke at a national government by pointing out how they compare to those in their immediate vicinity. So that if you're having trouble implementing change, then it can be helpful to have that kind of comparative metric as a way of.
And we also know there's a number of different preventative strategies that some national health systems take. Some almost have an opt-in approach to giving prophylaxis to patients rather than opt-out. I think the importance of the risk assessment model was to look both at the risk of thrombosis, but also the bleeding risk and make a measured judgment. So I think just measuring prophylaxis rates is probably not the way to go. I think we need to look at incidence rates more generally.
Fair enough. This is something that's been posed to both of you. Emerging research suggests that COVID-19 patients have a high risk of thrombotic events. So how do you frame your cause around relevant current events and avoid being labeled as just piggybacking on a hot topic? So actually, Nicholas, I'd like you to take that from a more general point of view first.
Yeah, I mean, on the one hand, it may look like cynical bandwagoning. On the other hand, it's a way of making sure you get your foot in the door and get the meetings. And it's, you know, this is real. You know, we're not making this up. There really is an increased risk of thrombosis for COVID patients. I should say, by the way, that my personal connection to this issue is that 20 years before I was born, my grandmother passed away from VTE just after my uncle had been born. So an obstetric kind of condition, and she was only 31. So, you know, this is something that has affected my family very directly. But that's not true of everybody in the way that polio was. But again, to say that this is part of the overall COVID picture, by addressing this issue, you are going to make your country's response to COVID look better because fewer people are going to die. This is a really powerful argument.
And have you seen that being effective, James, the connection to COVID?
I think you've got to look at the evidence. We've seen emerging evidence now that is quite clearly demonstrating that patients who have COVID have an increased risk of VTE. And as a result of that, you know, work work is being done at the moment with the World Health Organization on behalf of the ISTH. And actually the World Health Organization has come back and said, we are going to invite a hematologist to join the clinical guideline development group for the COVID response. And I think that is recognition indeed for the scale of the problem.
We have perhaps almost the opposite side of this problem. We see that the EU is going more and more, they're going into broad areas of activity, so cancer or cardiovascular. And how can a more specific topic or issue gain enough traction to become a priority as you start to see this more general approach?
Yeah, I mean, on the one hand, you say more general. On the other hand, what people are held accountable for is particular policy successes. And every politician who is making a speech about the generalities of a particular policy always wants to have a specific issue, a specific outcome that they can point to and say, because of our concern, our activities on this general issue, we've achieved this specific success. So I think it's placing yourself in that wider policy environment and showing that you're relevant and essential to the wider policy goals that the politician is trying to achieve, whether that's in the EU or a national setting.
Yeah, you have to be cognizant of the mood music that you're operating in. You know, firstly, I think data and linking it. So, for example, I think the question was, you know, with you going into more broader areas such as cancer or cardiovascular disease, we know that VTE is one of the top cardiovascular killers. You know, blood clots relate to that. So I think you've got to make it relatable. You've got to have that data and evidence. And you know, for VTE, certainly in the UK, it was deemed a Cinderella condition. It was so specific, but actually by demonstrating that it was a patient safety issue and that it was a quality improvement issue, we were able to get it on the agenda of those civil servants who had a responsibility for patient safety and clinical quality. And ultimately, we used the data of the incidents, the potential improvement that could be made, but also the cost to the system, the £600 million a year that is spent on treating, you know, post-thrombotic syndrome, suddenly made people sit up and listen. And
maybe to step outside of my bounds as moderator and talk for a moment about how this is actually part of the ETHA's current a method of interacting with the EU. So we see that the EU is really focused on cancer this year. It's a major priority of theirs. And obviously, well, the proof point that we're using is that thrombosis is the second leading cause of death in cancer patients. So if you want to address cancer, then you have to address thrombosis. And that making that point to policymakers really makes it clear that there's something specific that they can act on instead of just having, to Nicholas's point, instead of having to just tackle cancer in general, they can look at a specific action that can be taken to make a big difference in cancer. And that helps to both address our issue and then also show them what they can do about it. So it's good points from both of you. I have another one here for James, but actually to both of you, but I'll start with James. James, you mentioned that former England goalkeeper Paul Robinson, who was involved in the NHS VTE campaign, or that he was involved in the NHS VTE campaign. So how would you suggest approaching high-level speakers like him for involvement in public affairs campaigns?
So we were aware of this. It was a news story that he had, you know, been rushed to hospital as a result of this complication from surgery. And when we became aware that this indeed, you know, was a blood clot, we left it a bit of time. You know, he had to deal with his own medical issues here. But in time, we actually contacted his agent, I believe, and just asked, you know, whether or not he would be willing to, you know, lend his face to a campaign that was seeking to educate the public on the experiences that he's just gone through. And he was very gracious indeed, and you know, used his celebrity to, you know, really make a difference. So it has to be very sensitively done when you're certainly working with patients who have, you know, suffered a traumatic event. But yeah, there's ways you can do it.
So Nicholas, have you seen that that's an effective approach to involve high-level celebrities as a spokesperson for your campaign?
It has its pluses and minuses, and the minus side is that these tend to be people who are awfully busy and whose primary concern is not keeping you happy, there's a risk sometimes of a prima donna effect. On the other hand, when it goes well, it goes really well. I remember Javier Bardem helping me with one of my political campaigns in the past, and flipping heck, you know, you have a meeting in the European Parliament with Javier Bardem, 4,000 people turned up.
Okay, well, I have screamed right up to the stop time for our session today. Thank you really both for your for sharing your point of view, for telling us a little bit about how to mount a public affairs campaign. I think this has been super helpful, and I really appreciate those of you who joined on the line. It's great to have this coalition of our own of people who are trying to address thrombosis around the world. We welcome you to ask any questions that you still have on Twitter. We're going to be on Twitter via the ETHA and ISTH channels, we hope that this was helpful to you. So thank you again, everybody. Thank you to our panelists, and